Okay, we're going to get started. If everybody could take a seat, please. Thanks, George. Welcome, everybody. I'm Mike Cassidy. I'm the faculty director of the Rappaport Center. And I teach criminal law and evidence and legal ethics here at the law school. And on behalf of the center, I'm pleased to welcome everybody today to talk about what is undoubtedly the public health issue of our day, of our time, the opioid crisis and creative solutions to the opioid crisis. And we have two distinguished panels. We'll have a break in between the panels, but we have two distinguished panels of people who have been very involved in this issue for a number of years today to talk to us about the subject, what's going on in Massachusetts, how Massachusetts compares to other states. We have officials from Rhode Island here as well, so we're going to be doing some comparing and contrasting. I also hope we have an opportunity to talk about the governor's initiative that was just announced yesterday, stage 2 of his initiative. He's proposed a bill that would do a number of things, some of which are controversial, such as allowing doctors to issue 72-hour commitments, involuntary commitments. Also increasing the number of beds in Massachusetts using Medicaid monies and several other initiatives. So I hope, even though that's fresh breaking news, that all of our panelists today will have a little bit of a chance to talk about legal issues going forward and the likelihood of that passing the Massachusetts legislature. So what I'm going to do today is introduce the subject and then introduce the person who really helped us put this all together and who will be moderating our first panel, Judge Leo Sorokin, on my immediate right, a friend of the law school and an old friend of mine who really helped us conceive of this panel, these two panels, and put it all together. But let's just talk about the issue a little bit. The Center for Disease Control estimates that 175 people die a day of opioid addiction in this country. That is more people than die of guns and more people that die of car crashes every day. So it is not an overstatement to say that this is the public health emergency of our time. President Trump issued a declaration to that effect in late October, which brings with it certain monetary consequences for the states, but it also gives the executive power to circumvent certain legislative requirements in terms of initiatives going forward. So that was a very significant announcement. And our governor, Charlie Baker, served on that task force, as did several other Massachusetts officials. The problem is exacerbated by another crisis that's interrelated, which is the fentanyl crisis. The statistics show that between 2014 and 2016, of people who died of opioid deaths in this country, in 2014, about 19% there was fentanyl in the heroin that they were taking. 2 years later, it was over 80%. So we're seeing fentanyl and synthetic fentanyl mixed with heroin, which is one of the things that's contributing to the overdoses. So we have a law enforcement problem with the importation of fentanyl. We have the public health crisis, which is how people are getting addicted to opioid. And what we want to talk about today is, in our first panel, we're going to talk about how law enforcement and the treatment community can work more cooperatively, can share information in order to really get the people the assistance that they need. Sometimes we think of law enforcement and social workers and treatment professionals working at cross purposes, but we really need to have them working together. And then in the second panel after the break, we're going to talk about opioid addiction treatment in the correctional system, in our jails, houses of corrections, and state prisons, and what we're doing to treat people who are addicted to opioids in the prisons, so when they come out, they don't relapse. And we'll be having officials from the State Department of Corrections here in Massachusetts and officials from the State Department of Corrections in Rhode Island comparing and contrasting approaches and talking about novel approaches going forward. So I'm really excited for the conversation. Both panels, we're going to leave plenty of time for questions. Lissy has asked me, by the way, Lissy Medvedow deserves great credit for putting together this program. She's our executive director. If you haven't met Lissy, please do so. Lissy has asked me to remind everybody that if you're new to Boston College and you're looking to get on the wireless, the guest registration code is on the second to the last page of your program. Okay, so with no further ado, let me introduce Judge Leo Sorokin. I think it's fair to say that nobody in the criminal justice system in Massachusetts has been more involved in the recovery and reentry system and process for people who have drug and substance abuse problems than Leo Sorokin. He was the founder of the first federal drug court in Massachusetts, which was called CARE. I always forget the acronym. Court-Assisted Recovery Efforts. Do I have it right? Court-Assisted Recovery Efforts. He's also worked very closely with the Boston Bar Association Leadership Program and their Restart program, which is an initiative to improve reentry services both at the federal and state level. Judge Sorokin is a graduate of Yale College and Columbia Law School. After Columbia Law School, he clerked for the Honorable Raya Zobel in the District of Massachusetts, and after that he was an associate at Mintz-Levin. And after that, we joined each other working together at the Attorney General's office in the 90s, where we were colleagues, and he left the Attorney General's office to be a federal public defender for 6 or 7 years. So he has a nice mix of civil and criminal experience, and then he was appointed magistrate judge of the United States District Court for Massachusetts, where he served with distinction and where he was responsible for starting the CARE court in Massachusetts, and it has been a model for other federal district care courts across the country. And Judge Sorokin lectures and advises other jurisdictions on setting up drug courts all over the country in his spare time, of which he has very little. So his hard work as a federal magistrate was recognized first with being promoted to chief magistrate in Massachusetts, and then in 2014 he was appointed by President Obama to be a district court judge in Massachusetts, where he's been for the last 3 years. So I'm really, really excited that Leo could take time out of his busy schedule, as he so often does, and guest lecturing at BC and helping us by hiring our law students as clerks and interns, et cetera, et cetera. He's a very good friend to the law school. So please join me in welcoming Judge Leo Sorokin.
Thank you. So it's timely, I think, particularly for what Mike said, to have this conference today because of what Governor Baker released yesterday, a whole set of initiatives about opioids, and just recently the President's Commission's recommendations about the opioid problem. And I think it's telling that Mike called it a public health crisis, and that's what it is. But it's interesting because people are talking about it that way, as opposed to it being a law enforcement or criminal justice problem. And just the language itself, I think, is significant because it invokes different ideas, different people, and different concepts. It's one that the reason I talked to Lissy about doing this conference, and the reason I've been interested in this for a long time, is really something that Kim Hanton said to me a long time ago. When I was presiding over the care court, we used to meet every Wednesday, and it was a prosecutor, defense attorney, probation, and Kim would, for many years, was the treatment person who would come, and we'd talk about the people who were coming in, and we'd have a meeting, and I would ask Kim, we would just have a little social conversation before the meeting started, and one day I said to her, how's it going? And she said, well, I'm actually really overwhelmed at work. And I said, why? And she said, well, in the last 24 hours, we had this huge spike of increases in overdose and a huge spike in admissions to new treatment. And I said, that seems weird. I don't know why would that be? And she said, well, we didn't really have any idea, but then we realized that that same period, that same day, there had been this combined local, state, federal sweep in one town, where in one or two towns neighboring each other, the North Shore, where about 30 drug dealers were arrested. And the 24-hour spike that they had was essentially in the 24 hours following the execution of all the arrest warrants in that case. And so what she and I surmised was that all of the customers of these various drug dealers responded to their arrest of their drug dealer in one of two ways. They either went, that fact alone was enough to motivate them to go to treatment, and that's why the spike in admissions to treatment, or they found another drug dealer. And that other drug dealer was selling things that were different strengths or different strains or different drugs than they were used to, and that led to the spike in overdose. And I confess my own ignorance that it was, despite many years in the criminal justice system, it was the first time it ever occurred to me there was actually a relationship between the sale of drugs and the use of drugs. I know it seems obvious, but it wasn't to me. And I've discovered that connection is apparently not so obvious to a lot of other people too. And so it got me started on this idea that there really should be a collaboration between the law enforcement community and the treatment community. And because once law enforcement is arresting, say, a group of drug dealers, they have in their hands the names of all those people who went to Kim's organization either because they wanted treatment or because they were dying with an overdose or potentially dying. And so rather than ignore that information, pretend it doesn't exist, don't think about it, don't do anything with it, and do nothing, something should be done. And the second reason that really brought me here was a conversation I recently had with a federal prosecutor at a sentencing in a case totally unrelated to that first sweep I was telling you about, but something similar. It was someone who had been convicted of distributing drugs, and we were at the sentencing, and this particular defendant was part of a large sweep in a particular community where many drug dealers had been arrested all on the same day. And one of the things the prosecutor was informing me of, part of his sentencing argument, was that this was part of an effort to clean up, make the community safe for the people who live there, that free of the violence associated with drug dealing and all of the negative consequences that come from drug dealing. And this was heroin and cocaine the person had been distributing. And so I said to him, I said, how long is the effect in the neighborhood from this? I was actually just curious. And so, and in this case, in total, I think something in the order of 60 or 70 people were arrested, drug dealers, in one community. And what he told me was, well, 3 months on the low end, 12 months on the high end before the market reforms. And I was like, wow, 3 to 12 months. That doesn't seem very long for the incredible amount of effort that went into that. And I started thinking, what if instead of just doing that, that meant all those customers were still there after they arrested and took away all the drug dealers. And the customers are going to go somewhere else. And it just takes the illegal drug market 3 to 12 months to reform and other suppliers to come into place. What if something were done to intervene with those people and so that they would get treatment, and then maybe the market wouldn't reform. You'd take advantage of that window of opportunity that you have. So that's what's motivated me. That's what I'm really interested in. I think that there should be more collaboration in that way. And to the credit of one of the federal prosecutors in that case, I'll just tell you that I raised this. Did they do anything after the arrest of all the people? And if not, why not? And one of the things I said to them, which may have motivated them, I said, well, it may be that the United States government is incapable of doing anything, but I have personal information that the Arlington Police Department does. And I told them about a conversation I had with Chief Ryan, that the Arlington Police Department responds, is my understanding, we'll see if he corrects me, that when they arrest a drug dealer, they try to make an effort to deal with the customers of the drug dealer. And to this credit, this federal prosecutor, she called up Boston Police Department detective and got the detective to go out and give brochures about drug treatment to some of the people who were customers that he knew about off the top of his head from that investigation. And I thought, what a great thing. Maybe one of those people goes to treatment. That wasn't a lot of effort. Do I necessarily think that the police and the law enforcement are the people who should be doing all these initiatives? It's not clear. That's why I think it's collaboration. But collaboration requires communication. And in part of this, the law enforcement community has the information, and then it moves on. So that tells you why I'm here, why I was interested in doing this, why I talked to Lissy about it, why I was happy to help. I think it's really significant because these are people's lives we're talking about. I think you can't forget the fact that every person who dies of an overdose is somebody's child, and many of those people are the brother or sister of somebody, and many are the parent of somebody. And so this is real life for real people with real consequences, and which is a really good reason why everybody who has anything to do with it shouldn't do their best to try to do better than they're doing. Because there is something that the people in drug court taught me, which is if you always do what you always did, you always get what you always got. And so if we want to have a different result, it seems to me we have to think about how we can do better and do some things differently. So that's why I'm here. And that's what I think there's a lot of opportunity for collaboration. And I think that Massachusetts is actually on the forefront, from what I understand, of collaboration. So it's great to be here. And without any more, I'm going to turn it over to our first speaker. It's going to be Fred Ryan, Chief of the Police in Arlington. I will just briefly say a couple things. One, today's the first time actually we ever met, but we've talked on the phone a couple times. And I've been really impressed with all the things and fascinated by what they're doing in Arlington, because it seems like Chief Ryan is really interested in figuring out how they can collaborate with treatment, how they can take what they have and the information they have and do more with it. And he has a long history of doing that. And I believe he was called by the president to go to Washington to be there for the release of the Presidential Commission recommendation. So that tells you that he's in high esteem in Washington, not just in Arlington and Newton. So without more, Chief Ryan.
Thank you, Ron. You know, I have to share a story with you. When the judge first called me, I was in my office, and my secretary came and said, "I've got a federal judge on the line for you." Am I getting sued? Am I getting indicted? I've broken a lot of rules in this journey around the opiate epidemic, and I thought I'd finally get caught. But I was honored to receive that phone call and have a really interesting conversation about some of the same struggles that are going on really at the federal level and all the way down to the local level. So just by way of background, Arlington is really a microcosm of what's going on in America. We're a relatively small suburb of Boston, about 50,000 people jammed into 5 square miles, but a close-knit community. And in late 15, calendar 15 into 16, we were losing 1 person a month to the opiate epidemic, and really, losing an entire generation of kids in our community, and many more non-fatal overdoses. But we're experiencing about 1 fatal overdose a month. And I, like any other chief law enforcement officer, we have these fancy staff meetings, and everybody comes in with their rank, and everybody feels good about themselves. But at one particular meeting, I was frustrated. We'd had a couple of deaths, and I really challenged our team to come up with, how do we stop the bodies from turning up? This has got to stop in our community. We've got to do something differently. And our crime analyst, really brilliant young lady, soft-spoken woman, sort of chimed in and said, Chief, yeah, whatever, who's got the solution? What is it? And she put up a spreadsheet, and she very softly said, Chief, I think we know who our next fatal overdose victims are. I said, we do? Who are they? She said, they're right here. They're the people who previously overdosed. And, that was sort of the aha moment for me, where I realized that we had in our database the known population of people at highest risk of fatally overdosing in our jurisdiction, yet nothing was being done to prevent their fatal overdose, except to wait for the 911 line to ring and respond out and clean up the mess and move on to the next call. And that's where we began the conversation internally about what can we do differently. And for those in law enforcement in the room, cops hate change and they despise the status quo, right? Any change is met with resistance and self-imposed barriers to success. But we started talking about solutions. And on that spreadsheet, and I apologize, there are probably some in the room who have heard this story, but it really illustrates, I think, what's going on in jurisdictions all over America, that the system is letting people down. On that spreadsheet was one young lady's name. Her name was Kayla. And by all standards of measure, Kayla and her family were an American success story. mom an educator, dad a firefighter, she herself a graduate of the University of Massachusetts. Beautiful young lady. And Kayla's family called 911 after she overdosed. And we responded out and reversed the overdose with nasal naloxone along with our EMS partners and transported her to a Boston area hospital. Go down the spreadsheet, there were a few other fatals in between. There's Kayla's name again. 911, we responded out to the scene, reversed the overdose with nasal naloxone, transported her to the same Boston area hospital. 7 hours later, 911, and Kayla was dead. And if that spreadsheet and that experience doesn't illustrate the fact that the system of dealing with those suffering from substance disorders in our jurisdiction was failing, nothing does. And you know, we did a reconstruction on that case of sorts, and sort of try to figure out what happened here. And the reality is we thought we were bringing Kayla to a safe place, the healthcare setting, the emergency department, the Boston area hospital. The reality is that emergency department had neither the desire nor the capacity to treat overdose patients. They just wanted to get rid of them. They're a nuisance. And so that triggered a real approach from our jurisdiction on dealing with emergency rooms that we're bringing overdose patients to, and really becoming a part of the discharge planning and so forth. I'll talk about that in a moment. So what do? We embedded a social worker into the police department, and their first task was to take those more than 100 names in that spreadsheet, the known population of people suffering from substance disorders in our jurisdiction, and to go on out and start to begin doing some intervention planning, some outreach with these people and their families and their loved ones and roommates, partners, whoever was connected to their success, to begin some survival planning and intervention planning. But before I get into specifically what our social worker does, while we were having this internal conversation, up in Essex County, then Chief Campanello was rolling out his revolutionary program where he and his jurisdiction were inviting people into the police department to try to provide them services. And who would have thought the lobby of a police station would become access point to treatment? But that's what was going on up in Gloucester. So that triggered some conversations between then Chief Campanello and I, and the organization known as the Police Assisted Addiction Recovery Initiative was founded between Chief Campanello and businessman John Rosenthal up in the city of Gloucester. And what has happened since then has simply been extraordinary in terms of the numbers of people helped. The New England Journal of Medicine has studied what we're doing and validated what we're doing. We have recovery coaches here today affiliated with PARI. You guys want to raise your hand? You know, they're doing great work embedded in the Everett, Mass. Police Department and other police departments. And we're looking at the back end of bringing people back into the community. But back to the program in Arlington. So there we are in the staff meeting, or a subsequent staff meeting. And we get our social worker. We're going to start doing some outreach. And of course, you know, cops are great for putting up self-imposed barriers of success. So we need to get Narcan in the homes of these people. We need to develop a survival plan. We need to develop an intervention plan with these families. Chief, we can't give out Narcan. Well, why can't we? Well, I don't know. The regs say we can't give out Narcan. Well, somebody call the legal department and get me an answer to that. So we're working on developing our plan. The staff member comes back and says, yeah, Chief, I checked with the legal department. We can't give out Narcan because if you have a pharmaceutical license and you do it without authorization, it'll get revoked and you'll lose your license, Chief, to ever get a pharmaceutical license. And I thought, well, I'm just a kid from the projects with a degree from state school. I don't ever intend to become a pharmacist, nor do I have the intelligence. Great, let's give out the Narcan, I'll suffer the consequences. I'd rather prevent death and dying in our jurisdiction than get caught up with CMRs and regs and really bureaucracy that's preventing success. So we began to develop really a two-pronged approach with that known population of people suffering from substance disorders. Was one, as I mentioned, a survival plan. We put together a kit, really like a handshake, to get to that person suffering and their family to develop a survival plan. And we were chatting earlier, really the mindset was the same mindset we applied many decades ago to cases of domestic violence. I remember then DA Harshbarger talking to law enforcement saying, we've got to help these women in abusive relationships plan for the next assault to prevent their death. Now, law enforcement had been approaching it, you need to leave this batterer, you need to leave the home. He's a bad person, he's going to kill you. We all know there were many valid reasons why women weren't ready to leave abusive relationships. We needed to be smarter about the way we were policing domestic violence. So we started doing safety planning with women who were in abusive relationships to ensure their survival. That same mindset we applied to those suffering from a substance disorder. There are many reasons why people suffering aren't ready to get into treatment. We need to get over that and build a survival plan to ensure that they can survive until the point when they are ready, when they're at their rock bottom and ready to get into some long-term treatment. So we developed a protocol, a plan to do survival plan. That was like the handshake to get into the door. Then our social worker would switch gears and begin to work with loved ones and family members around a more long-term recovery plan. And the mindset we tried to create there was, if your loved one suffering from a substance disorder was expecting a child, you'd have a robust plan in place, right? You'd know who's driving to the hospital, you have a bag packed, you'd know who the healthcare provider is, you'd know who the doctor is, you would have a very well-established plan in place. We want to apply that very same mindset to your loved one who's suffering from a substance disorder, to put this plan in place, because if we wait until that person comes seeking help to begin the planning process, we've missed our opportunity, because that window is such a narrow window to be able to, if you start the planning then you've started too late. So with that, and all of our internal planning, we did our outreach meetings in the community and Narcan meetings, and as the judge said, I was invited by the Trump administration to go down to the White House at the end of October. That was one of those, you know, no matter who occupies the office of the president, it is the President of the United States who invited you to the White House. Now, here's this self-described liberal Democrat from the Commonwealth of Massachusetts, invited by the Trump administration to go to the White House. So I had one of those, what the hell do I do with this? You know, but as I thought about it, and as I learned more about the invite and what would come from it, you know, I decided to go. And what happened was fascinating. We had a lot of policy meetings during the day. Governor Christie, who ran the commission, was there. But I got to meet our new United States Surgeon General, Dr. Jerome Adams. Fascinating young man. He's become my new text buddy. And we're driving policy through the Surgeon General's office around some of the stuff we're talking about. And so it was a fruitful meeting. You know, obviously getting to meet the President of the United States is an honor, and to stand with him while he announced the public health crisis. And in closing, I just want to talk a little bit about what the judge spoke about, and that is, after two of the fatals that I spoke of, we have back-to-back fatals. You can research a case for those of you law students or law people here, United States versus Bain. And Bain sold his poison to two people in Arlington. They killed them. And so we quickly tasked our one of our drug control officers that's assigned to a federal drug task force to go out and work this Bain case. And they quickly put together a trafficking case, trafficking fentanyl-laced heroin, killing people in our community, had all the elements, guns, drugs, money, the whole 9 yards. And when the law enforcement team briefed me on this case, both federal and municipal law enforcement guys and U.S. Attorney's Office folks, you know, and my guys are basically looking for the blessing to do the search warrant and the arrest. You know, I was utterly amazed by the quick work and the collaboration among all levels of law enforcement to quickly put together a case on this guy to stop the death. A couple of follow-up questions after the briefing. The judge touched on it. Question one, do we know the identities of the people that are buying their poison from this guy? The answer is yeah. We've been doing this investigation, Chief. We've got a whole list of names here. Follow-up question, what are we doing tomorrow when we unwittingly create a public health crisis in our own jurisdiction to prevent these people from going out and finding a new dealer and potentially getting more harmful poison? Or are we seizing this as an opportunity to get some folks some resources they need in terms of a survival plan and an intervention plan? The answer was, Chief, we're doing nothing. So after Bain, I issued the order of my jurisdiction that any time our drug control officers come seeking authorization to do a search warrant and arrest warrant on a drug trafficking case, that there be a parallel social services plan, so that when the deal has been neutralized and it's safe to kick in action on the social services side of the house, that we begin to knock on doors and seize these as opportunities to get people help and direct them into treatment rather than incarceration. And that's my story, and I'm sticking to it. Thank you, Your Honor.
Thank you, Chief. So next, we're going to hear from Kim Hansen. Kim and I, as I referred to before, known each other for a long time. When I started the care program at the federal court in 2006, Kim was then a treatment provider for the U.S. Probation Office, and she was one of the first treatment providers who staffed our drug court. And in fact, I had met Kim before that because she was a staff person in the Chelsea District Court Drug Court. We had observed that court a number of times in planning and developing our own program. So Kim has a lot of experience in both state drug courts, federal drug courts, and she works at North Suffolk in treatment programs, running and creating programs. So without more, Kim.
Will be still my heart, because just to hear, as Judge Sorokin had indicated several years ago when him and I were kind of putting our heads together, trying to figure out what's going on and how can we do this better, and then I hear to the right of me, this is actually happening. This is wonderful, and this is all about relationships. As I've been a treatment provider for over 30 years, dealing with addiction, dealing with the individual that's suffering with addiction, dealing with the families, and dealing with the communities. And the key piece to all of this, as I sit here right now and I listen, and also through the years of my experience, is communication and relationships. Because this is key for us to do a better job. And when Lissy had called me and asked me to sit on this panel, my expertise is with treatment. So I can talk to you about stages of change in the world of addiction, and I can talk to you about what the best connect for modality of treatment is to somebody who's presenting with different symptoms. I can talk to you about the ACM model and how to place people. But then I looked and I said, they want creative solutions. These are things that we've been doing for years, and really what is on the foreground right now. And we've been trying to infiltrate communities, and I can talk about all of the connects that I have in Revere, Winthrop, Chelsea, Charlestown, Boston, and working on the streets with the door knocking that we have in place with overdoses, as Chief Ryan had talked about. What we're doing in these communities is we're putting teams together that are responding to non-fatal overdoses as well as fatal overdoses, and going into the community and working with the families and providing them information and engaging them and meeting them where they're at. And the key component to all of this is recovery coaching, and I heard that there's coaches out there. And so that's the piece that I really want to talk a little bit about today, because I think that's a piece that may be misunderstood, and I really think it really bears discussing what a recovery coach is, what the expectations are of them, and how we can move forward as a society and really infiltrate this service model into the world that we're working in. Because there's also a fear that I have. I so much want this service to be accredited and to be credible, And I do know that there's a lot going on out there that would contradict that. So I really think it's important that we understand what the role of coaching is and what the expectations of them are. In the model of care that I provide in my clinics, recovery coaching is attached to every service modality that I have in place. From the minute that you walk in the door to rapid access, to any treatment modality that you're placed in. That could be outpatient, that could be individual, that can be group, that can be intensive model of care, that could be residential, and that could also be a transitional step-down model. I also embed recovery coaches, as I said, in all of these communities, and the purpose of that is to really meet the drug user where the drug user's at, and engage them and provide them with a safe conversation. Because recovery coaches are people with lived experience. But the most important part of that is they're also educated and trained with lived experience, and the key piece to this is educated and trained. And they are held accountable for what they do, and they are overseen when the model is done appropriately. So let's be really clear that there's people out there, that are saying that they're recovery coaches, and they're out there and they're doing some rogue work. And that's challenging. It's challenging for me, who sits here, who accredits and really wants to make this level of service something that is embedded throughout this state and something that is provided and served efficiently. I don't have any valid data, but we've done this, our own internal quality management piece to really kind of understand where recovery coaching is going and how effective it is in the work that I do as a treatment provider. So what we did was we did this research project in which we identified people coming into intensive outpatient model of care, and we took the numbers. In the retention of people that were assigned a recovery coach from the day that they walked in and through their journey was 22% increase. And I know that may not sound like a lot for people, but in a treatment world, those are large numbers, because retention in treatment is challenging. It's challenging for the individual because this disease, as some may know or some may not know, is the biopsychosocial. It's a disease of the brain, and I'm sure you'll be hearing more about it this afternoon from Dr. Wally. And it really needs to be treated on many different ways. So it has to be treated from a medical perspective. So when we talk about that, we talk about medical assisted treatment. We talk about ASAM assessment, which is the American Society of Medicine, where they have specific criteria that individuals have to be met, so that you can place them and where they belong on the continuum of care. So these are all pieces that we have to contend with as treatment providers, and we have to make sure that we follow within the guidelines of mass health systems, systems that are regulated through the Bureau of Substance Addiction Services, through the Department of Public Health. But we're also treating this individual, and sometimes they can fit into this little box, and sometimes they can't. So that's where coaches become such a significant part for me to work with, because they can work outside of the boxes that sometimes that we're placed in. So if anything is heard from me today, it's really for people to research recovery coaching, research recovery supports, get behind this model of service and have an understanding of it. But also, as community work, Chief, you really have an understanding of what's being accepted as coaching too, and really be an advocate that it has tremendous oversight, that it's not just being sent out there in this vague, undermined, non-oversight service, because it's really important that it's attached, because that's where we can make a difference. The recovery coach are the ones that engage. The recovery coach are the ones that are using motivational interviewing to get people to really understand that they're not here to enforce their model. They're not here to enforce what their understanding of recovery is. They're there to listen. They're there to provide guidance. They're there to navigate. They're there to work with you when it comes to the criminal justice system. They're there to work with you when it comes to the treatment system. They're there to work with you when it comes to your family system. And these are all systems that maybe are not talking to each other. And they're not talking to each other because of trauma, because of, you know, denial, all the tools that these family systems put into place, because that's how they survive. These families survive by not having people come in and really kind of take things apart. So it's important then when people come into these families and people are working with drug users, that they have an understanding of where they're at. And I know that my treatment, my creative approach to treatment is not controversial. So you will hear that in a little while, and I'm really excited about what you're going to hear, because we are making a difference, but we're nowhere near ready to say we have this. So any questions when the time comes, I'll be more than happy to.
Thank you, Kim. I want to, before we jump to Gary, just say one thing about recovery coaches, which is sort of interesting related to this topic of collaboration. Am I right that all three of you are from AmeriCorps? Right, so what's AmeriCorps is created slots that they have filled, and the people who take the slots, like the three recovery coaches here, are embedded with different law enforcement departments. So one is at Everett, you're at Burlington, and you're in Lynn. So different police departments, and I know that they're still, I think they're still staffing up. So it's just an interesting collaboration, and it sort of goes to the question of what the chief was talking about and says, okay, what's the plan the day after? The plan might be, and maybe, is that to have, you know, uniformed law enforcement officers do some of the follow-up, but it may be in particular places the plan is some of the follow-up happens with a social worker embedded, or with a recovery coach, maybe from AmeriCorps, maybe not, or by a relationship with a treatment provider. So there's a number of different ways to do it, and that's just an unusual way, which is a great collaboration between really the federal government, which runs AmeriCorps, funds it, and Perry, which is operating these or managing these slots, and then the particular departments that people are embedded in.
In Revere and Chelsea, they are doing it with
There as well,
recovery
right,
coaches.
right.
And who would have thought we would have had a recovery coach academy at the Arlington Police Department? When I first became a cop, you know, and I thought I'd be having an academy for recovery coaches at the police station, I would have told you, you were smoking crack, right?
Yeah.
But that's what we're doing. You know, it's fascinating.
Right. So that brings us to Gary Langis? Langis, I'm sorry, who is a self-described opioid historian, who was there at the time, at that point in time when the chief was saying there were no recovery academies in the police department. He's been working with this problem and issue for 50 years, so he's got a lot of experience, and a lot of experience working to urge, lobby, or force institutions and our culture to change our approach. So look forward to hearing from Gary.
You know, the chief Ryan and myself, years back, he would have been sitting on this side of the table, I would have been sitting on this. This is a lot of progress, sitting on the same side of the table as the chief, judge, things like that. You know, I started my research in opioid use in 1966, and I spent the first 4 years down in Harlem, New York, until 1971. So I have a lot of experience, and I go from, you know, everything that I've done in my life, it's self-learned. I don't have a degree, I don't have a PhD, I don't have a master's, but I've learned a lot in my life. And this opioid crisis that we're going through now, it's always been here. It's just been It's just been contained in small sections, like urban areas, poor areas, brown areas, black areas. You know, I traced our drug laws back to 1870, the first opioid laws, and they were rolled out on sort of racial lines. You know, the first drug laws in the 1870s were they were targeting Chinese men in San Francisco. They were laying with white women. Okay. And we come up to the Harrison Act of 1914, and there were, like, if you read the hearings and read some of the testimony in the hearings, you'd be totally horrified with the language that they used. You know, and I'm not even going to say it because I'm a big believer on trying to reduce stigma. I've changed my language over the years, and a lot of the work I've been involved in started out with HIV prevention work. I was a retail guy until I saw my community becoming impacted by HIV and AIDS. And I saw a lot of my friends and my family dying from a disease that we had no answers for. There was no medication for. And a lot of it was being transmitted by injection drug use. I lost my own wife, and she passed away in 1993 from HIV infection. And other family members, and my friends, you know, and I got started in this, like I left that work that I was doing to become like a rich person that was gonna, like, you know, retire to the Keys and take out fishing charters. And today, like, I'm still not down the Keys, but, so I've had to watch a lot, I witnessed a lot of the opioid crisis going on, expanding. I track drug trends. When we talked about the fentanyl in 2016 in June, I went out with some folks from the University of California, Berkeley, to track fentanyl trends. They were doing the whole country, but I was the New England contact, so we went to like Worcester, Lawrence, and Lowell, and Nashua, New Hampshire, and we talked to folks, we did interviews. We purchased 7 grams of supposed heroin that when it was tested, there wasn't, every bit of it was tainted with some amount of fentanyl and other drugs. So a lot of the research that I've done, it's been, and I've worked with some great mentors and folks, you know, in the activist world, starting out with syringe exchange in the 1980s. And they've taught me a lot, but I think the most I've learned is from the people that are using drugs. My expertise is I work with people who use drugs. They're not in pre-contemplative stage, they're in pre-contemplative stages, but like at the beginning of they're not even thinking about treatment. They're using drugs. And the work I've done is provide low threshold health services for that population. Like it's abscess care, overdose prevention, HIV, hepatitis C prevention, and a lot of the work had been done in shooting galleries. Years ago, I was up in Lawrence and Lynn, and I'm glad to see, you know, you're working in Lynn. I have a history of 13 years of working in, more than 13 years. I worked from 1990. I started a program down there, and I went back to it in 97, and I stayed there till 2010, and it's like one of my places where I love, you know, I don't know why I love these places like Lawrence and Lowell and Lynn and Brockton, and you know, like, but that's the way it is, you know, like it's a gift to me, you know, to do harm reduction work in these cities, and that word I just said, harm reduction. I've been at conferences where I've been told you can't say that. I've been inside jails doing education where they said you can't practice any harm reduction strategies in here, or we'll throw you out. You know, federal conferences saying you can't use that word. You know, I'm so grateful that it's come this far that like the law enforcement are involved, because this is about collaboration, okay? And I've been on the other side for a long time. My early days of research, I was on the other side of law enforcement. I was on, like, I didn't want to see a judge. If I, you know, like when I had to see a judge, it wasn't good news. And over the years, I've been arrested for doing the work. I was arrested in 2001 for exchanging syringes in the city of Lynn. I was put on trial, jury trial. I was tried. I was facing 100 years, and the judge made a deal with me right up front. He says, Gary says, if you're convicted, we're only going to give you 2.5 years. And I looked at him and I said, I'll take the 100 years. I'd take the 100 years, because then I'd start a program inside the jail. I know what I do, because that's what I do. And that's what my colleagues do. We do stuff like that. We push public health. We push them to make a move. Like with syringe exchange, we started syringe exchange 7 years before it became legal in Boston and Cambridge. And then it was a battle until 2006 to get it accepted in the rest of the state. But HIV infection among injection drug users dropped 90% after we had syringe access. 90%, are you kidding me? What kind of public health, what kind of numbers do you see that happen to? The Narcan distribution, we had a Boston's Buyers Club in 1999, where I was working for an organization, the New England Prevention Alliance. We were a group of activists that would go around communities. We were pains in the ass. I know we were. I know. Believe me. And we go to the Worcesters and the New Bedfords, and we set up tables on Main South down in Worcester, and start pass out syringes. And in '99, I met a guy in Miami from Chicago, and his name was Dan Big, and he's one of my mentors. And he was telling me about a program that he was doing with a doctor. The doctor was writing prescriptions for naloxone, and he was passing it out to his needle exchange participants. And I said, well, geez, that's a great idea. And we talked, we planned, and I brought some naloxone back to Massachusetts. Just for my crew in Lynn. Like I said, I have some naloxone. I can, do this stuff. I'm practicing medicine without a license, but hey, listen, what are they going to do? Okay. And and through doing that stuff, doing that groundwork, we went on for 7 years until I got caught in a local city around here, and I had to talk to some folks, got introduced to the Boston Health Commission. We collected all the data. They said, this is a great idea. And they started a pilot project in Boston. The following year, they started 8 programs in the Massachusetts through the state. And where I was working, we got funded to do that work. So it's all the work that we used to do, and they used to chase us around and write stories about us in the paper and tell us, we're all doing that now. And in 2010, I worked with the Revere Fire Department. They implemented the first naloxone program that they carried naloxone on all their units. I worked with Lieutenant Glenn down at Quincy. They carried naloxone. That was the only 2 cities back then, and then it just spread out. Because it's not going to happen from me. It's going to happen from other chiefs talking to other chiefs. That's how this stuff happens. I met with a chief for a long time, and we didn't. We went back and forth for a long time. But after a couple of years, the culture started to change. The language started to change. Junkies turned to people from the drug-using community. That's a big culture change in the department. Not using that stigmatizing language. And right now, I'm working on reducing public injection. So we see people overdosing in Dunkin' Donuts and McDonald's and in alleys and down in Boston on Boston Commons. You know what? I don't want my grandchildren to be walking down the street and watch somebody shoot dope in a car. I don't want to have visitors come up from North Carolina and walk through the public gardens and watch a person overdose and die. And these things have happened. These things have really happened, in our public parks. I don't want to have retailers having to pull blue people that are dead out of their bathrooms. I want to work on safe consumption facilities. They have them all over the country. Some of them 30 years old. They have 120 of them up and running in other countries, not in the United States. This is 30 years old. There's never been a fatal overdose because folks are being observed. They're getting connected, and that's my main word for this year, connected. They're getting connected with like services they need. And we can walk them along a path. Some of them may never stop to use drugs. But from my experience, I see at least 85% of the folks that I've worked with seek treatment. And sometimes that treatment doesn't start with like, you know what, I want to get you into treatment. No, it starts with a peanut butter and jelly sandwich. It starts with like, I care about you. You know, what do you need? What can we address that's going to help your life out tonight? You know, it happened like a couple of months ago with a Bosnian guy that we worked with for 2 years, a young gentleman, and he texted me, he said, I'm hungry, I'm broke, I don't have any butts, and I'm homeless. And I worked with him for 2 years. His mom had just died like 6 months ago, and you know, he reminded me of my son. My son wasn't Bosnian, but like, you know, he was like 20-something years old, and he had passed away, like he passed away 12 years ago. And you know, I like sort of adopt these kids, and I met him with another outreach worker. I went down, I said, all right, come on, let's go. We went up to the store, got him a pack of butts, walked him down the beach. I said, what do you want? Can I get 2 slices? I said, what would you like? He says, can I get a pepperoni pizza? Give him a pepperoni pizza. I slid him $5 on the way out the door. An outreach worker called me the next day saying, you know what, he went into Boston. He went to the PATH program. They got him into a detox. That kid's still in treatment today. He went to a holding, this is what he did. He chose to do this. I just met his immediate needs. Pepperoni pizza, a pack of cigarettes, and $5. Hey, that's unbelievable. That's low cost. So, you know, there's a lot of things we can do, but it does come down to the collaboration. You know, I work in a lot of states now, providing technical assistance to programs funded by the feds to do overdose prevention, and tribal areas, tribal nations. And they're looking at Massachusetts. They're looking at Massachusetts because we have been on the forefront for a long time on this overdose prevention. And, you know, I'm proud to be, you know, sitting up here with these folks that are doing what we can do to address all of this stuff, you know, because it's about a family, it's about individuals, about a community. And, you know, I love the door knocks that we do, and it's just building relationships and reconnecting unconnected people back to their families, back to their friends, and back to the community.
And that's how we met the young man, the young Bosnian.
Well, oh, that's right. We met him on a door knock like about 2.5 years ago. Yeah. I think that's it. All right.
Thank you.
I'll go on.
So what we're going to do now is sort of I have a few questions for some of the panelists, and if, along the way, if you have questions for each other, that's fine too, and then we'll open it up to all of you to ask questions. So the first question I thought I would ask, and just go down the line starting with you, Chief, is what, if there were one thing, but maybe first you could give us a specific example of the plan you were talking about that came out of that Bain case, not necessarily in that case, but the kind of plan that you would form when an officer's come to you and want to do a drug investigation. What kind of follow-up plan are you looking for? What are the specific kind of components?
Right. So really the important piece is the known population of people in our jurisdiction that are suffering from a substance disorder. And so one way to identify that known population is through criminal investigations into drug trafficking. You know, I talked about the other way, and that is, you know, 911 calls for the we see every non-fatal overdose as an opportunity. You know, and that's why the red and all the dots on the maps drive me crazy, because behind every dot is a person, a family, whose love, his faith is, you know, they're not just dots on a map. These are, you know, these are human beings, and we've dehumanized people in many ways through the stigma associated with addiction. So we try to humanize them, but so it's another way to identify that known population in your community that's an opportunity to do outreach and do prevention with, and you know, there's really sort of 3 ways: the drug control investigations, the 911 calls for the non-fatal overdoses, and the beat cops know who's using in their beat. They absolutely know. A good jurisdiction with legitimate community policing practices have cops that know the problems in their neighborhood. And so those officers in our organization, the culture of our organization, are encouraged to get that information to our social workers so that we can turn around and do outreach. I mean, we had a woman, I mean, this is fascinating stuff. We had a woman whose child was in crisis late Friday afternoon. She called the police and said, I need help, this kid's gonna be dead by Monday. Now, the traditional response would have been go out and lock him up for possession of Class A substance, heroin. And, you know, we kicked our social worker into action. I think she, you know, and I'm gonna say this, and, you know, the judge will probably have me indicted next week. We sort of had him using in a controlled environment while we worked to get him placed, but we kept him alive. You know, and that's what's fascinating. And I've learned so much over the past, you know, who would have thought a police chief would talk about medication-assisted treatment options? I was reading a medical research piece today about the comparison between Vivitrol and Suboxone, and how, you know, there was this big debate as to whether Vivitrol is really an effective treatment option. It is. The data is abundantly clear. So these are the things that really change, and because it was the #1 issue in my jurisdiction. And so how do I, as the police chief, not take that seriously?
So just to circle back, so one source of information for the social worker would be the 911 calls, the non-fatal overdoses. A second source of information would be information that a beat cop knows that there's somebody in his or her neighborhood that he's patrolling or she's patrolling that has a drug problem, and would be passing that information on to the social worker person to follow up with, do that kind of follow-up with the family. And then a third would be, say you're doing an investigation into X, who you suspect is distributing narcotics. At the conclusion of the investigation, X gets arrested. Then what happens in that scenario? Would it be that on the phone? Would it be as a result of the investigation?
Yeah, it would be outreach. So once the target of the investigation's been neutralized and it's safe to do so.
Right. Post-arrest.
Post-arrest, the social worker is empowered to take the information provided by the criminal investigators to go on out and engage in outreach activities.
So the criminal investigators might know, here's 4 people who were customers because we were surveilling him and we saw him sell, and here's their phone numbers and here's photographs.
Exactly.
And you take that and you go follow up with them.
Only when authorized, you know, we don't want to compromise the criminal prosecution, so there's some control measures put in place.
Right.
To ensure that, yeah. You know, Loretta Lynch, I had another one of those phone calls. The Attorney General's on the line for you. Oh, Maury? No, Loretta Lynch. I almost fell off my, holy moly. So it's a staffer of hers who puts me through to the Attorney General. Hi, Attorney General. Got invited to one of my favorite restaurants in South Boston with the Attorney General to talk about this very topic. And it was just fascinating to hear such a simple concept to get the attention of the United States Attorney General. Unfortunately, she was at the tail end of the Obama administration and never really got legs because, you know, the feds do a lot more of these cases than we do at the municipal level. But, you know, this is a concept we need to get pushed down, and it's one that I'm talking to the Surgeon General about, in fact.
So if there were one, what would be one?
It was Del Frisco's, by the way. Free lunch paid for by the Attorney General.
That's pretty good.
Yeah.
Yeah. Attorney General must have a bigger per diem than judges. And,
I couldn't have a beer, though. It's the only time I've ever been there without having a beer.
So if you had one, if there was one thing you could think of, you'd say, gee, I wish treatment could, realistically, not like a vaccine or whatever, but realistically, what's one thing treatment could do? You think, gee, if treatment did this, that would help us, law enforcement, do our job better. What's one suggestion you'd have for treatment so you could more effectively collaborate? What would you tell the treatment community that you would want from them?
Oh, that's an interesting question. I guess the answer to that with a two-prong. One is, and it's happening in Middlesex County, I don't want to steal the sheriff's thunder, I know he's here in the room, but to get those that are about to be reintegrated back into the community on medication-assisted treatment options to ensure their success as parolees or probationers, so that we drive down recidivism and really crime in the community.
Right.
You know, so I know the sheriff will talk about that, and he's doing great work in Middlesex County, which is catching national attention. On the community side, it's more collaboration. I think we're finding out, you know, I showed up at the scene of a fatal overdose. It was a corrections officer from Massachusetts, brother of one of our police officers. And I went to offer my condolences. I don't normally go to the fatals, but this involved the brother of a police officer. And as I offered my condolences to the young man, he was literally dead on the other side of the wall. I'm offering my condolences to the family. And his mom said to me, oh, you know, thank you for the work you're doing in the community around opiate addiction. We were just so ashamed to come out to one of your meetings and get Narcan and to do the things you're talking about in the community. However, this young man was connected to a treatment provider. And so I think there's so many barriers around treatment providers not yet in their silo, law enforcement in their silo, you know, corrections in their silo, and to seize those opportunities
So
to break
regular
down.
meetings.
Yes, almost like what we do in the with the prosecutor's office. What do we call them? A CBJ meeting, community-based justice meetings, where we talk about. We need to take the mindset. We talk about those at highest risk of reoffending the community in terms of criminal activity. Who are those at highest risk of overdosing in the community? And what can we do to prevent their fatal overdose? And to break down those silos and those barriers to get people. Because everybody, you know, HIPAA will be known as the public policy that harm more people than ever helped. And so, you know, everybody throws up the HIPAA, whatever. You know, let's violate that too. Let's save lives. And so it needs a little risk-taking and leadership.
Okay. Gary, what about?
Can I just respond to that, just because it's a perfect opportunity, do you mind? Only because it's real important.
There's a bunch of people calling me in right now. I'm going to be indicted tomorrow. You know.
No, because they-
Will
I'm
you
not
guys
sure
visit
HIPAA-
on the-
it's on-
You know, I don't think HIPAA applies to you.
Yeah, but HIPAA does apply to me.
Yes.
And that's where, you know, and that's
Yeah, right,
where, you
right.
know,
Well, violent.
the challenge becomes is because we are regulated and, you know, we are bound. So there are those pieces, but I don't disagree with you. You know, HIPAA really is a challenge at times when you really can't move forward. And right now, just, I mean, so people can note this and really maybe take a look at it at another point in time. There's a program out of Canada, it's called Hub and Core. Okay, and this program actually brings stakeholders in community, in this identified community together at the table once a week. So, and they're really working on trying to eliminate HIPAA and confidentiality agreements. And they're really, and they're finding ways to be able to do that. And the city of Chelsea has been doing this now for 2 years. So it is worth communities looking at. It's called Hub and Core, so.
Yeah, you know, excellent point. But HIPAA is so misunderstood, right? So the one Boston area hospital that we were getting frustrated with, we went to their emergency department and said, hey, can we get on the discharge plan? So if we bring John Doe in on an overdose, and he gets discharged against medical advice or whatever within the short window of time of us bringing him in, can we be notified so we can deploy our social worker? Oh, no, that's HIPAA. What do you mean it's HIPAA? We knew his name when we brought him in. We know who he is. We know what his diagnosis is. It's not a HIPAA violation. Legal won't allow us. So now we have this sort of informal wink and a nudge agreement where if we do bring somebody in, we'll get the call. But you know, it's that misunderstanding and misapplication of the statute that drives us.
And I think we're getting closer towards making some changes in that, because I'm actually working with an emergency department right now and doing very similar, you know, so that we actually with our recovery coaches can, you know, exchange information, but because of our MOU and our legal department, their legal department, so there are.
But it's such a sense of failure. We brought a guy in.
Sense of failure when somebody goes to the emergency room and then they overdose promptly after.
Yeah.
So one thing you really want is to have the emergency rooms tell you when somebody's leaving, so you know they're coming back to the community and you can follow up with the social worker and follow up with the family.
We brought a guy in, and the next morning I show up at my office, the phone ring, it's a neighboring jurisdiction police chief, John Doe's dead. And it's that, oh shit, you know, we had him.
Right.
You know, we had him, we brought him to a healthcare setting. How did this happen?
Right.
You know, so that's the frustration.
Reverse, Gary, what would you want, if there's one thing, if you only got one, that you'd want law enforcement to do to help you do what you're doing better?
Stop locking them up.
No, I haven't been locked up a long time. But, Jesus, you know, like, again, I work with a lot of law enforcement today, you know, all over the country. Like, I do a lot of first responder work. I've done a lot of, like, you know, when the state was passing out their grants around in the lock zone. I did a lot of work with the law enforcement then. And I love where I go out, right? Every week I work with law enforcement. It's the best team I think I've ever worked with. I swear to God. And like, you know, these are young guys, like, I can remember when we were going around the table and we were all introducing ourselves, and I get to this guy and he says, yeah, I'm John this. And I says, oh, I said, your grandfather was the first one to ever arrest me. You know, I'm working with this kid now. You know, I feel like I was thinking about it this morning. I think Chick would have been really happy that we're working together. You know, and he knew my son. You know, like, so it's like a family type thing, but we were talking about on the way over here, like, you know, it's so easy to work with these guys. I mean, I'm sure I can say some things to get myself in trouble, you know, around, you know, I wish they'd look the other way, and like, you know, we could open up a little heroin, hydromorphine clinic, and maybe Dr. Lawley will talk about this a little more, but where we can, you know, people know what they're using, instead of like, it's a crapshoot out there.
The safe consumption facility.
A
So really,
supervised-
one thing
supervised
was
consumption
supervised consumption
I think
facilities where
that
law
would be
enforcement
it.
would allow you to do it.
You know, because it's 2 weeks ago, 3 weeks ago, one of the visits we did, it was a 16-year-old boy. He had been out smoking some weed. He said, I wanted to snort some coke, and he got some coke, and he overdosed. It took 6 doses of 6 doses of Narcan to reverse the overdose. He had bought fentanyl. You know, so we don't know. Drug users don't know what they're using. You know, and I'd rather regulate a lot of this stuff. I think, you know, we've demonized, like you say, we've demonized drug users to where now it's coming home to roost in our own communities of Wellesley and Arlington and Marblehead. You know, like all of these communities that, like, you know, they didn't experience like all the death. And, you know, that's horrible. It's like, you know, I work close with Learn to Cope, a parent support group. And there's not a week that goes by that a parent doesn't, like, you know, lose a child. That really, like, you know, I mean, I feel that every day. And I'm grateful for that group, because we can refer, like when we go to a house and it's a parent saying, I just don't know what to do. Well, then that parent needs the support. It's not the drug user that we're supporting at the moment, it's that parent. And, you know, like, so I think, you know, we're working a lot better with law enforcement, and I think the conversation has started. We have a long way to go. There's a lot of work to do. You know, there's a lot of work for all of us. And with the new synthetic opioids coming on the scene, it's changed the whole landscape of opioid use. You know, like it's scary. It's scary, and it's coming in here like by the hundreds of kilos. It's coming into, it's particularly Massachusetts and Ohio. We're like the 2 petri dishes for the Sinaloa cartel. That's what we are. We're petri dishes, and it's like an experiment. But this is big business, and like, you know, I don't, you know, like the Bales guy, we can arrest him, but like, you know what, it's about money. When it's about money, it's about greed, it's about like power, and it's about, you know, like these people are like the Fortune 1000s.
But, and this is
And
important, just
yeah.
briefly, if I may, Your Honor. This is important, and we've made this argument. Those who push back against safe use sites, I think it's because of the stigma associated with addiction. And I counter with this. The current state of the law in the Commonwealth of Massachusetts is that we enable unsafe use sites through the Good Samaritan Law. The Good Samaritan Law allows people to use and access 911 when there's been an overdose without fear of prosecution. They're using unsafely with poison that's not created in a controlled environment. Yet when we go to talk about harm reduction and safe use sites, the pushback you get is, oh my gosh, that's horrible, it's terrible public policy. Well, the public policy we have now allows unsafe use sites.
That's right.
We need to turn that on its head.
Kim, what would you say?
Well, my dream is right here, right now, because I have law enforcement and I have a federal judge listening to my 30-year partner here, talking about safe injection facilities.
Work wife.
Yeah, work, oh yeah, oh yeah.
I'll have a domestic.
But I mean, and that's, and for me, it's process, it's all about process, because that's, you know, where I come from, and just, Gary and I, on our way here today, we were talking about the two gentlemen, we work every Tuesday night with first responders from the city of Revere on the door knocking, and we work with fire and police, and the two, the police officer and the fire officer that were there with us last night, we were talking about them because we had been with them probably about a year ago, and just the conversation that, you know, changed, and Carrie and I had co-designed a cultural competency training for the first responders in the city of Revere, and when we rolled it out for the police department probably about 2.5 years ago, it was met with such hostility and resistance, it was overwhelming. It was funny because we knew it was going to change the climate and change the conversation and change the culture of the city, but we knew it was going to be a lot of work. And you know, one of the police officers in, please forgive me, but all he kept saying was, fucking junkies, you know, I mean, and there was actually 3 or 4 of them that were saying it, and it would just continue through our entire
Put on an
2.5
order, that word's
hour.
prohibited now.
Yeah,
and a
and
lot of
it was a
times
2.5 hour training, and through the whole night, it kept going on and on. At the end of the night, Gary, you know, we kind of wrapping things up, and things got really, you know, it was kind, and it ended up getting to a nice point. And Gary turned around, and we were talking, you know, we were ending the night, and he just looked over and he said, oh, and by the way, I'm a fucking junkie. You know what I mean? And just the way he said it, and it was like, and they all did, they just looked, because they had such respect for the information that he was given, to see that in a whole, and so
Said it was
that's,
an Irish
you know,
bro,
he
though,
did, he said,
because
because
it
the
was
guy
an
was an
Irish-
Irish bro.
I'm a fucking, you know, 'cause that's.
It was, but,
Officer was.
but that's what it's all about. It's
I've been on a lot of
communicating.
panels, I haven't thrown that out.
Yeah, they did. But it's just important that we keep talking and talking and having relationships.
And listening.
And listening and listening and respecting what each individual brings to the table, and that's key.
So I'm going to pose the question to myself too, and tell you about one thing that we've done at the federal court, which is a form of collaboration, sort of with law enforcement, but not exactly law enforcement, which is we stand in the middle at the court at a sentencing between, what comes before is pre-trial, between the person's arrest and their sentencing, when sometimes they're in jail and sometimes they're out in the community. And what follows after the sentencing, which is typically, in the federal system, the person goes off to the Bureau of Prisons for a prison sentence, and then they return to the community on something called supervised release, which is mandatory in the federal system, and is basically probation after prison. So in the federal system, in prison, there is an extensive inpatient treatment program if you have a serious substance abuse disorder, and if you're able to get into it in terms of space and the like. And what we were finding was people would do that, would go to that program, and then at the end of that program, the Bureau of Prisons would send them, and that program is not just treatment, but it's actually a special housing unit. So if you're in the prison and you're doing that program, everybody in the program lives together. And the reason is it's like a therapeutic community. And the idea of the program and the people who run it is that when you're in that, you shouldn't be in general population. And they never want you to go back to general population after you've done that, because they feel you lose the benefit of that. And it's essentially a form of inpatient treatment for, how long is it? Do you know, Joe, or Chris, is it like, it's 500 hours or like?
500 hours.
500 hours, so it's probably like 15 weeks or something. And, but then they would send those graduates, along with every other person from federal prison who was being released to the community, to a community halfway house for 6 months. So they wouldn't have put them in a general population unit in the prison. They put them in a general population unit in the community. And our experience told us that once you do inpatient treatment, you really want to be in a residential outpatient treatment program. A general population prison program in the community is not outpatient treatment. So actually, probation, the federal probation officers here and I worked for 3 years? At least 3 years. To persuade the Bureau of Prisons that what they should do is allow people who are coming out, instead of going to the non-treatment community program where you could go out to treatment, but there's no treatment in the house, to go to a residential substance abuse treatment program licensed by the Commonwealth, where we would send someone who was on probation who went to inpatient treatment afterwards. And so now, actually, we are doing that form of collaboration. We actually pre-screen for the prison people for their inpatient program and identify them when we send them off. And when they're done and graduate, if they're coming here, we're the only federal court in the country doing this. Instead of going to after the inpatient treatment, they can go to 6 months at like Hope House or one of these other residential treatment programs in the community before they're completely released to live at home or what have you. So it's an example of essentially just connecting the railroad cars together. And I bring it up because I think that there's, the chief brought up sort of what's happening in terms of medicated assisted treatment with people at the tail end of prison. And the idea of thinking about these as continuum of what happens to people when they're in prison, then it may be a different government entity, maybe a different jurisdiction even, but communicating with the people who are supervising and responsible for the person in the community once they return to the community, to build a sort of seamless approach as opposed to everybody in their silo is a significant improvement. And we've just begun this in the last year or so, and so it's just a handful of people who've gone through it, but we're very hopeful of that and hopeful to incorporate actually medicated assisted treatment into something like that. So Lizzie, I think I would open it up. Yeah. So if any of you have questions for any of us? You do, yes. If you just say what your name is and what your question is.
Yeah, sure. My name is Haley Evans and I'm a 2L here at Boston College. Thank you all for being here. I'm not sure if you're familiar with the case that was argued recently in front of the SJC about whether or not requiring drug testing as a condition of probation is constitutional or not. And so essentially arguing that because they're in the midst of disease, requiring them to test if they relapse, isn't helpful or isn't even constitutional. And you mentioned drug court briefly, and my understanding of drug court is that model is highly dependent on testing as part of the treatment. And so if it were to come down that
Is the claim in that case, I think I might have heard some of the case, but I'm not particularly familiar, is the claim in that case that because is the claim that the defendant has a disease, and because he has a disease, he can't be subjected to court-ordered drug testing?
yes.
So I can't speak to the legal issues presented by that because I'm not familiar with the case enough, but I would say this in response to your question. Yes, drug courts are very extensively used drug tests because they're one of the few very reliable indicators of whether in fact somebody is using drugs or not. And they're used, I think, generally in drug courts first to determine whether the person needs more treatment. Much the way in a medical setting, you would use a medical test to determine, I think we need more treatment for this person because their problem is emergent. And they might need more antibiotics, or so in a drug court setting, we would look at the positive drug test and turn to somebody like Kim and say, what do you think the treatment intervention is? Do you think they need to go to inpatient treatment? Do they need more sessions? What do they need? What's going on? We would also look at it, because it's typically a violation of law and a violation of your conditions of release, as what's the sort of judicial coercive response, that is what sanction in drug court language would you impose for the relapse. And because there is an aspect to most drug courts, it's essentially behavior modification theory, that that's why drug courts meet frequently, because the idea is you want to respond to the behavior as close in time as possible, because that's when the person will most connect, they most need the treatment before they cycle out of control, and they most connect whatever response, whether it's you don't give them credit for a week, or at the other end, whether they go to jail for a day or two, connect that to their behavior and maybe causes change.
And I can't speak to the legal aspects of it, but I can speak to the treatment aspects of it. And urinalysis, urine testing, is used as a tool for our treatment provider. It's one of the tools in our box, but what we also teach and encourage the person that we're treating is that we're also supplying that as a tool in their box. Because part of a symptom of the disease of addiction is the lack of ability to sustain and not be impulsive. So therefore, this is a tool for them knowing that they're going to have a toxicology screen, to really give a minute to think it through. So once again, and they also have to meet with medical criteria from a treatment perspective, so it's not really a mandate from the courts. When you're in treatment, we're using it as a medical model because insurances are covering your toxicology screen. So, you know, it's twofold. So your question about the legal aspects, you know, is something that I think really does need to be explored better because we are using this as a tool across the board. So if we have to change a law, if we have to rethink this and relook at that, we should, because when we remove this tool, it really can be challenging.
Yes.
Hi, my name is Jessica Federelli. I'm actually a BC alum, but my question is about, so say there's a sweep, a federal sweep or a state sweep, and you have a lot of dealers arrested, and you know that there's going to be new dealers coming in, and you approach your known users. Do you ever ask them to reach out to you when they get approached with samples or when they get approached by the new dealers that want to recruit them as clients to work with law enforcement to faster identify who the new dealers are that are going to come into that community and fill the void?
Our social worker does not use any coercion or try to leverage the situation to get criminal intelligence. It's solely focused on public health, getting the person the support and resources they need to get into treatment rather than incarceration.
That would destroy the relationship.
I will tell you, I don't obviously do that because I'm not in that role at all, but I will tell you that in the federal system, under the federal sentencing guidelines, if a defendant, any defendant in any case, provides substantial assistance to the prosecutors in the prosecution of another person, and if the prosecutor thinks that that person has done that, the prosecutor, so all this authority is vested in the prosecutor, can make a motion to the court and ask the court to give the defendant a lower sentence to reflect that assistance to law enforcement. The way the language of that rule is written right now, that the prosecutor can only make that motion for work that the individual has done to help in the prosecution of another person. And I have made the suggestion when I was speaking before the United States Sentencing Commission earlier this year that they amend that provision and leaving the way it is, but add to it to authorize federal prosecutors to, if they thought it appropriate in a particular case, to be able to make the motion if somebody provided assistance in identifying and helping to get other human beings into treatment. And it seemed to me that would be a pro-life position. There are defendants who come into the federal system who are unable, who might wish to cooperate with the authorities, but are unable to cooperate because they don't know anything that would help. And it wouldn't require anybody to do anything. But so it's a little bit different than what you raised, and it would be it's just be up to the person and their lawyer and the prosecutor. So far, the commission hasn't adopted that. But Mike.
Thank you all. Terrific comments. Kim, I had a question. It seems like one of Governor Baker's proposals is to use Medicaid expansion money to create more treatment facilities and more beds, but also to require DPH to tighten up on regulations on approved facilities. So I'm wondering how you feel about whether the facilities that are currently in operation need that tightening up, so that there needs to be more state oversight over the quality of care issue. And also, I didn't quite understand whether the recovery coaches are currently accredited or are not accredited, and if they are not accredited, is it part of the Baker's proposal to accreditate them, and how do you feel about that?
As far as DPH licensing goes, the regulations that are imposed to any current DPH license programs are pretty stringent and pretty strict. So as a DPH license, I have DPH license programs and a continuum of care, and the oversight is pretty, as I said, pretty stringent, and they're what they require for us to do. So I can't imagine it really becoming tighter. They really require a great deal of they protect the consumer a great deal, and as well as it should be. as far as expanding into it, I think that's wonderful. I don't think we have enough treatment programs. I definitely don't think we have enough residentials. I do believe, I'm a firm believer in really kind of taking, the drug-using brain when it's ready to remove itself and placing them in a safe environment where they can change some of the behaviors. So if we're talking about treatment, that's what we're talking about. And as far as coaching goes, right now, as we stand in the Commonwealth of Massachusetts, we currently do have a accreditation program. So, but right now, I think there's only 5 credentialed coaches in the state. Am I right? Do you guys know? Because there's a process in which a recovery coach needs to go through a 5-day intensive training, and then after that, there's approximately, I think, like 1,500 hours of trainings that they have to be provided in order to become accredited. And they also have to be under 800 hours of supervision by an accredited supervised recovery coach. So I think right now it's a stringent and it's very challenging program for folks. That's why right now we only have 5. North Suffolk actually employs 3 of the 5 that are accredited, and that's because we really are very closely, we're working very closely with the Bureau to ensure that this accreditation does continue to happen, and really designing and developing. We were on the team that developed the supervisors training for the state. So yes, I do believe it's a resource that can be utilized. It's also a resource that can be very harmful. So I think the oversight is so necessary, but I do believe the state's aware of this, and I do believe that the state's doing everything in their power to do so.
Right up in the back, yes. You.
Hi, my name is Sharon Beckman. I'm on the faculty here, and thank you to all of you for coming here for this incredibly interesting program. I wanted to pick up on Haley's really excellent question about the use of drug tests, and as the Judge Sorokin and Ms. Hanton illustrated, that the tests are used in both contexts, but to very different ends. So in the judicial context, the drug test can be a basis for punishing the person, criminal punishment, whatever the end goals are. The means is punishment. In the medical or diagnostic question, it's to help treat the person, and presumably their treatment is voluntary, but this is an important tool, like in other medical contexts, to know whether the treatment is working and to assess and so on. And this leads to my question, which is I feel very excited about all of the things the panelists are discussing and that the chief is discussing about ways, for example, law enforcement can do less harm, right? And can have the opportunity to be, to do good. But my question is what you think about the idea of stopping to think of this as a criminal problem and moving more towards thinking of it as a medical problem, and taking funding that is currently in law enforcement or the judicial system to deal with or treat people who have this disease, and move it instead into the medical and education system. So a question of resources. So I see the problem like it's kind of percolating up through the criminal justice system. So the criminal justice system is trying to respond to it. But why don't we as a society just say this is a serious disease and these are human beings like human beings with other diseases, and it would be more effective to put more money into treating it as a medical problem? And I'd be interested in each of the panelists' different perspectives on that question.
So I would say, first, I'm a judge, not an elected official, so I don't make policy, I just apply the law. And so as to the larger question, I think you're exactly right. The reason people in the criminal justice system are addressing it is because it's coming up. People are getting arrested, we see these problems, we see ways that we could do better at what we're doing. Whether the, I think the statistics in the federal system are something like 40 or 50% of the people in federal prison have some sort of substance abuse disorder. And how that should be dealt with, and whether you can separate that completely from criminal conduct that leads them into the judicial system, and how you do that is a question sort of beyond the scope of the individual cases that I might be adjudicating in a particular case. I think that what you're getting at, I suppose, in the larger question is really, should we be locating within the criminal, whether it's in the police, federal law enforcement, or judges in courtrooms, the sort of coordination of, which is what happens in a drug court, of a multifaceted response. And that's I think it's arisen because that's just where it is. And whether, in a reactive sense, that's where it's been. Whether that's the smartest public policy way to do it, or whether there wouldn't be more effective ways to do it, and whether you couldn't do it more cheaply or more effectively, or both, in a different setting. But I mean, that,
That's my question.
I don't know, it may be. I mean, it's true, the reality is that I can send, if I send someone to prison, there's no limit on how, the fact it's $30,000 a year on average in the federal system, but no one ever questions my ability to do that. There's never any concern about what it would cost. You just do what's right in the individual case. But we do think about, when we send people to inpatient treatment, which is very expensive, whether we're sending them, if someone is released on bail, or someone on the back end after they've been in prison and they're on supervised release, we do think about the cost and how often we do it, because it is very expensive and we don't have an unlimited budget. And so there's practical considerations at times that inform what's going on. And that, it's a great question, but I'm not sure I know the answer.
It's the whole supply-demand debate, right? And so we've lost the war on drugs. So is it time to shift some existing resources from the supply side to the demand side? And if you look at what we've done with tobacco and seatbelt use and a whole host of other very difficult public health issues where we've made a whole lot of success outside of the criminal justice system, we need to start, penalizing relapse when relapse is a part of recovery illustrates a problem in and of itself. That's the whole debate. And so it's a proportional thing to me. It's a time to start shifting some of those
would be changing, rather than what you're suggesting is a massive wholesale, it would be very difficult to accomplish. One thing I've always thought that would be useful is if people were measured, law enforcement were measured on a metric instead of, as sometimes happens, how many people did you arrest? Or how many, that kind of metric. You were measured on a metric of how many overdoses were there, how many shots were fired. When students come to the courthouse and I talk to them, I ask them if they hear gunshots in their neighborhood. And if they're from Boston, they raise their hand. And if they're not from Boston, they look at me like I'm disturbed. Like, who would hear gunshots at night in their neighborhood? And because you don't hear that if you live in the suburbs of Boston, by and large. And so, but if the metric were that, is there gunshots, are there home invasions, are there, what events are occurring that are public safety events, I think that you would begin to see or accelerate the shift.
And it's about being smart on crime. This whole notion of being tough on crime. We can criminalize everything, warehouse people, and just let them recycle, and that's tough on crime, right? In my jurisdiction,
It's tough on criminals.
Yeah,
not
tough on criminals. In my jurisdiction, arrests are down, and so is crime. So if I had it my way, if we could have 0 arrests and continue to drive down the crime rate, that's a good place to live. But that's difficult work, and it's sophisticated work.
And it is a medical disease, but it's a medical disease that manifests itself in behaviors. And some of these behaviors are criminal behaviors. So that's why it's so vitally important that we are merging and we are working together to fight this disease, because it's the only way that we're going to be able to do this. We need to do this together.
But I agree with the judge on metrics, because arrests are down, and I go to get my budget funded, and I get questioned, well, arrests are down, crime is down, we need fewer cops. No, exactly the opposite. We're doing good work. Why penalize good work? But that's to the judge's point, the metrics are incorrect.
Last word, Gary.
Yeah, I think it's, listen, it's scary, I just agree with the chief so much, and there's so many more similarities than our differences. That was not always the case in my life. And, I think we lost this drug war a long time ago, probably when it started. From not looking at this as a public health emergency, during those early drug laws, it took it out of the hands of public health, took it out of the hands of docs, and we've been practicing this way for decades and decades and decades and decades. That's gotten us here. And what's it really provided for our society? More people incarcerated than any place in the world. Privatized prisons. Like, this is like something that, like, you know, years ago, like, it's like a Clockwork Orange type stuff. It's like, what are you kidding me? Like, I never really, you know, I mean, I saw people going away to prison years ago, but like what it had become, where we have more than 2 million people in prison, but like a lot of them for non-violent drug offenses because they were a drug user, because they were like had substance use disorder, and it really, you know, like it just has caused a lot of the laws have caused more damage than help. And I think I think it was Jessica here talking about, you know, this is to reduce harm. We want to reduce harm. The law enforcement, you want to reduce harm. You know, like, I just like, you know, celebrate this working with you folks now. It's,
Let's go to Del Frisco's.
There you go.
Oh, let's go.
All right.
I'll take you to a place in Revere.
That sounds good. Well, thank you very much to the panelists. There'll be a 15-minute break, coffee outside or right over here, and then the second panel.